Welcome back to NurseEdScholar. So today, I'm going to walk through another NextGen NCLEX style, case, um, covering endocrine emergencies. So I'm going to be going over DKA and SIADH. You know, I started creating these types of videos because I want students to really think step by step through the clinical judgment model because all nurses are really going to need to think and as you start working, you kind of go through all six steps kind of at once. But when you're starting out, it's best to kind of learn each step and know what you're doing and why you're doing it. And that's why I always stress when I say, please don't memorize content. You have to understand what's going on to determine, what's the next best thing or what's the priority or what should I be doing first. What is going to protect my patient and keep them safe. And so we're going to be going through these case studies, and I'm going to be breaking down step by step what you should actually be thinking about, um, when you're taking care of your patients using the clinical judgment model. All right, so before we kind of jump into all of this, let's look at it. Let's think about how the NCLEX really wants you to think and how they're going to test your knowledge of information. And every next gen case is kind of built around the six steps of the clinical judgment model. And so with these two case studies, we're going to be going through this together. So of course, the first is recognize cues, analyze cues, prioritize hypotheses, generate solutions, take action, and evaluate those outcomes, evaluate those interventions. And if you kind of remember and follow this process, you'll stop guessing a lot of the times and you'll start really thinking like the NCLEX. Okay. So let's begin. All right. So let's start with this case. So you have a 22-year-old patient with type 1 diabetes. You go and you take a blood glucose and it's 480. You notice that, their respirations are rapid, they're deep at 28. You notice a kind of fruity breath odor and they have dry mucous membranes. And so, what cues are you recognizing with this patient? Okay. So hopefully you recognized, you know, that the patient has hyperglycemia. You looked at that 480 glucose. You noticed the Kussmaul's respirations, 28 a minute. They're deep, they're rapid. Remember, that's blowing off CO2. And we'll talk about this in a second. You should realize that ketones are present because of that fruity breath and dehydration. You should notice that because the cues, um, you know, were the dry mucous membranes. Okay. And these are classic findings for diabetic ketoacidosis or what they call DKA. All right. So now we're going to move into step two. We're going to analyze, what do these cues actually mean? You need to recognize that the patient doesn't have enough insulin available. Remember that 480 blood glucose. Um, because because the glucose can't enter the cells, the body needs energy. So what is it going to start doing? It's going to start breaking down those fats. And those fats cause the production of the ketones. Okay, so that's where you have that fruity breath. And those ketones are going to cause metabolic acidosis. Okay. And so those Kussmaul's breathing, that's that respiratory compensation. So the lungs are trying to compensate by breathing faster and deeper. They're trying to blow off that CO2 from that metabolic acidosis. And that's why you see those Kussmaul's respirations. Now let's move on to prioritizing. So, you know, when it comes to this, you're thinking, okay, what is the most life-threatening problem right now? Is it severe dehydration? Is it the metabolic acidosis? Is it the high glucose? Okay. Um, how do you know you're coming up with prioritization, and it's like, okay, you have these things going on. So what is the most life-threatening for your patient at this moment? You're going to um generate solutions. So let's go back for a second. Um I forgot to mention the answer. So the answer is the metabolic acidosis. That is the most troubling problem with your patient, um, because the pH is off. The patient's acidotic. And so when a person is acidotic, everything is affected in the patient's body. Their cardiac function, neurological status, the cellular function, everything is thrown off. And so we just don't want to focus on glucose. We want to focus on the most dangerous thing. And at this time, that will be the metabolic acidosis. So now that brings us to this. So now we're looking at, okay, metabolic acidosis is the most life-threatening thing of my patient right now. So now I need to, come up with ways and solutions. And we know we do not diagnose and we don't treat, but we need to be aware and be proactive of what interventions the doctor is going to order. And then, you're generating solutions because you know that something's wrong. So when you call that provider, you're going to anticipate what they're going to order for you to provide, the care that you're going to be giving for your patient. So we're moving on to generating solutions. And so what kind of solutions, would you consider? Think about fluids, think about insulin, electrolyte monitoring, because at this stage, we are building our plan of care. We're not actually acting yet. We're just thinking of what would the doctor order? What would the doctor order? What can I start bringing by the bedside? What can I start anticipating? Okay. And so the key question is, what do I do first? you know, and when you think about it, you go back, you say, okay, this patient is having metabolic acidosis. Um, they're breathing rapidly, they have these dry mucous membranes, the acidosis is going to affect all parts of the body, but what should I do first? And the answer is you're going to give IV fluids. You know, understand the patient is severely dehydrated and fluids restore the circulation and improve perfusion of your patient. If we give the insulin first, we risk worsening the patient's hypotension. Um, and then you want to look at potassium, because we're going to have to monitor the potassium. And then, people may say, okay, well, we want to give some bicarb because of the acidosis, because the patient has metabolic acidosis. But that's really used in severe cases. But for this and for DKA, you really want to think of first, I want to give fluids. I want to restore the perfusion, and then I'm going to administer the insulin. And then you're going to say, hey, how do I know that the interventions that I provided for my patient, how am I actually going to know if it actually works? I mean, worse. I'm sorry, how do I know that my patient has actually gotten better than worse? And that's what I meant. So, we're going to have to evaluate the outcomes. How are we going to know that our patient is actually improving? So once we start giving the fluids and restoring the circulation, once we start giving the insulin, we should start seeing, okay, my patient's glucose is decreasing. I should see the respiratory rate normalizing. Remember, the patient was breathing at 20, 28. Uh, Improved level of consciousness, better hydration. Remember, the patient had the dry mucous membranes. Evaluation is really critical. And, remember that the NCLEX wants to know that you understand whether the intervention worked or not, right? So they may give you a whole scenario and then they may ask you, well, how do you know that this worked? How did you know the medication worked? How did you know whatever intervention you provide? How do you know it worked? what cues do you see that the patient is actually getting better? Okay, so let's move on. All righty, so now we're going to shift to a different endocrine emergency. And this one, the patient has low urine output, they have weight gain, they have confusion, and their lab work is showing a sodium of 120. So what would you think would be going on with this patient? So this patient has SIADH, um, and based on the cues that you recognize, you'll see that the body is retaining too much water. Um, you notice that there's water retention. The patient is gaining weight. Um, you'll notice neurological changes because of the low sodium. So the patient will start exhibiting confusion. And so you're going to say, hey, I recognize these things that are happening to my patient. So what else is going on? Okay. So you're thinking, okay, this person has an excessive antidiuretic hormone. And remember, antidiuretic, diuretics remove fluid out the body. So if you have excess antidiuretic, well, then that means that the person isn't diuresing. And so what's happening is that they are retaining fluid. And because of this fluid, they're diluting the sodium. So now you have hyponatremia and you have fluid overload. Okay, so what is the priority with this patient? You're thinking, all right, severe hypernatremia, neurological risk because of the diluted sodium. We talked about the confusion, and it also places that person at risk for seizures. And so now, we've gone through, you're recognizing, you're analyzing, you're looking at, now we're generating solutions. And so, well, we created hypotheses. So now we're analyzing, we're generating solutions. And so the person's fluid overloaded. So now you're saying, okay, well, hey, I'm seeing order for fluid restriction. They have hyponatremia. So I'm gonna have to monitor that sodium. We know that the low sodium causes seizures, so now we're going to have to place this patient on seizure precautions. And then we're going to say, okay, well, what medications may be ordered for my patient? So uh, I got to generate some solutions, but the main thing is that, okay, out of all of these solutions that you're thinking of or you're anticipating from the doctor, what is the priority right now? And so that priority is fluid restriction. Think about it. If you give more fluid, so a lot of people may think, okay, well, the sodium is low. I need to give them saline because the saline's full of salt, and you're thinking, okay, if I give them more saline, that would correct the hyponatremia. But you have to realize giving more fluids can actually worsen the problem. Patient, you may think, oh, my patient needs diuretics. Diuretics may be used, but it's not the first step. With this, the solution is, I don't want to say simple, but the solution is simple. We want, that your patient has too much fluid, too much water. And so we'll want to restrict it. So we'll put the patient on a fluid restriction. And that's what you're going to be anticipating from your provider. And so now we're come to evaluation. How do you know all of the steps in the clinical judgment model, all of the, interventions that you provided for your patient? How are you actually going to know that it worked? You know, you should see the sodium improving. You're going to be monitoring those labs. Every single lab that's taken, you're going to be making sure, okay, that sodium should be coming up. It should be coming to normal. So I'm going to make sure that I'm monitoring my sodium levels. Their mental status should be improving. The patient had hyponatremia that can cause confusion, and the sodium, as it corrects itself with your interventions, the patient's mental status should get better, right? And then fluid status, that should actually stabilize. The person was uh, fluid overloaded. And so with the interventions, that patient will start to diurese, and then that would actually stabilize the condition of the patient. And so, that's it. The main thing is that I say things kind of over and over again because I want you to recognize that there is a pattern. The NCLEX is not really asking, what you know. It's asking kind of a lot of times, what would you do first? And using that clinical judgment model will help you go through all of the steps. Um, you really have to think about patient safety and patient priority. And that is what the NCLEX wants to know if you can recognize that. So I want to thank you for um, coming on to Nurse Ed Scholar. If you like this video, please give it a thumbs up, subscribe, turn on those notifications so you'll know when the next video is up and running. And I don't know, that's it. So happy studying from Nurse Ed Scholar.